I think we're about to start. So welcome. I'm Marifu Caballero. I shall be facilitating this session, and due to the kindness of Louis Henry from Royal Marsden Hospital in UK, we have a presenter today to share the knowledge that is needed amongst nursing teams. So as you join, please put your name in the chat with the country, just so that we have a record of it. We ask that you mute your mics and with the video off, camera off. And then the whole session will be led by Louis Henry for the first part. And then we will end with questions and discussion. Over to you, Louis, if you could introduce yourself. Thank you.
Oops. Okay, I'm just going to share my slides, so if you just bear with. Hang on a sec. There you go. Can you see that, everybody?
Yes.
Yes. Lovely.
Yes.
Okay, so we're going to make a start. So I'm Louise Henry. I've been doing this a very long time. I had dark brown hair when I started. And so here I go. I'm a dietitian who works at the Royal Marsden Hospital, which is a primary treatment centre for children and young people. And so our age group I work with are the 1 to 25-year-olds. Over my career, I have cared for a number of patients with advanced disease and those receiving palliative care, and I thought I would share some of my experiences with you and would love to hear what your experiences are. Let's just think about today's presentation. I've got a lot to cover. We might not get through it all, but my idea would be that we have a little look at the research. We look at why nutrition is so important in this and its role, and also limitations of what it can provide. Look at the methods of nutrition support you might like to consider. And then if we have time, we'll have a case study and also maybe some thoughts on why this patient group particularly drawn to the use of alternative diet therapy and how to support them. So why aren't you moving forward? Here we go. So WHO define palliative care for children very clearly. And as you can see, nutrition sort of fits in, and the provision of nutrition fits in really well within this description. And I've highlighted to there, I feel very strongly that as providing nutrition is definitely multidisciplinary, and in a patient with advanced disease, it's very important to be working as part of the wider team if you're the person who leads on nutrition, and to have an understanding of prognosis and any possible treatments. Health providers must also evaluate and alleviate physical, psychological and social distress, and I think we can definitely agree that nutrition is part of that. Yeah. So does research have the answers? No, there's very little research, mostly extrapolated from adult care, partly obviously because the patient group to study is relatively small, and they are unique. So every patient's experience of palliative care will be unique. So drawing a broad brush recommendations is difficult. A few years ago, I was involved in a project that looked at end-of-life hydration and nutrition provision, which was a pan-London project, and I put the reference up there, and we'll look at the algorithm a little later. So I've looked into the adult literature, and that can be quite useful to think about. And I remember many, many years ago going to a presentation by a nurse from the States whose PhD was called Meal Times and Other Losses, and she looked at the experiences of carers and the importance of communication, as many people didn't completely understand that reduced appetite, reduced intake is a normal and natural part of being in the palliative care phase, nearing end of life. And when you look at the other literature, so looking back to work from the early 2000s and then as far back as Holden in 1991, you find that there is a dichotomy between the patient's experience and the carer, where the carer is finding it much sadder and more stressful. So expressing the loss of the social aspects of feeding, the loss of role and identity as the person who prepares foods, being worried that their loved one is dying of starvation. And as we know from work in physiology, that generally patients are not dying of starvation. in that advanced phase disease, because there are other mitigating factors which we'll look into. On the other hand, the patients, who are in this case obviously adult study, would overestimate what they were eating and reported positively on it, and wanted to have less pressure placed upon them, and being allowed to just simply eat what they felt they could manage. So interesting for us to learn from adult experience. So let's have a little think, what does food mean to us? You know, we had a maternity leave do yesterday, and I made some South African cakes for my colleague who's South African, and she was absolutely overjoyed. We bought her some beautiful presents, but it was the cakes that stuck with her. And I think all communities, all cultures, all families, all individuals, food is so much more than the provision of nutrients. It's a way of showing love, it's a way of caring, of showing nutrition. It's factors that are very complex around what you choose to eat, including, you know, have you got food poverty, biological imperatives. For instance, if you're anemic, you might crave some iron-containing foods. Lots of health beliefs, which is what we're probably going to be. We focus a lot on exploring people's social and cultural and religious beliefs around food. So food is really complicated, and it's not simply a question of, because if it was that, it would be so much easier for us if everyone just ate the same and they all ate a perfectly balanced diet. It is a very complicated phenomena. But then you add you add a large layer of complexity by looking at patients who are ill. Food takes on a different meaning in illness. It can be a positive meaning or a negative meaning, but also you tend to find that in most cultures, again, and in different communities, and even within different family groups, there will be different foods that you define as being the foods you eat when you're ill. I often, when I have student nurses, will ask them, oh, well, what did your mum give you to eat when you were poorly, when you were little? And you get some very surprising answers. So the most surprising one I think I've come across in a long time was warm lemonade, which was from somebody in there whose family are from the Caribbean. I know that flat Coke is used extensively in the US. In the UK, I think sort of plain invalid food, soup, jelly might be perhaps one of the foods that people go to. Often people saying Heinz tomato soup, for instance. So food has a different value and meaning above the normal meaning in ill health. What does it mean to our families? Well, it can mean an enormous amount of things, not always very positive. I mean, we see a lot of children who become increasingly fussy or controlling around the brand of food they will eat, the format that food needs to be. And so that full source of control can come much more to the fore, even with relatively young children, although obviously perhaps more noticeable in our older children and teenagers. It also falls the other way. You can have parents controlling access to food. They perhaps have decided their child needs to eat lots of fruit and vegetables, and so you might find that you're getting a lot of micromanagement of dietary intake, or people striving for an ideal. It can show hope. People find great comfort in food. It can show that you love. And the moment your baby's born, you're asked, you know, how are you going to feed baby? And that's it. As a parent, your job is to feed your child. And my children are 26 and 30, and I still am concerned. One of them has decided he's going to become vegan. So I'm sending him lots of information about vegan diets and balance. And so that doesn't finish, you know, it doesn't go away. And I think for the majority of parents that we're dealing with, they are very invested in providing food for their children. But we also have the negative side around food. And again, this working from adult work and pediatric, well, limited amount of pediatric work, there's, in my experience, a lot of anger and guilt and regret around diet. So I'm always very clear to say to our parents and carers and the patients, the older patients, it's nothing you ate. This did not cause the cancer. This doesn't make your symptoms worse. They are already dealing with enough. They do not need to be thinking about the role of diet. Was it something mum ate during pregnancy? So it's important, and often perhaps we forget to emphasize that to our families, that we really do let them know that it is not their fault that this is where they're at. We can also, as healthcare professionals, get in and perhaps help rein some of the conflict and frustration that can come around food, and perhaps provide reassurance. Again, a patient with an advanced disease, with a palliative prognosis, with a life-limiting condition, if they don't eat 5 a day, does it matter? No, it doesn't. And if the parents are anxious about being told, no, it's fine, you don't worry, they can have salt, they can have this, all these things that they've been told like children shouldn't have, it's always worth explaining that obviously the health eating guidelines are ideal. They're something you should follow for the long-term health, and in the short term, an aberration from those guidelines is absolutely fine. Dread can be another thing that I come across with people both the patients are dreading meal times and the families are dreading meal times. And we can perhaps go in there with some useful practical advice about limiting time of meal times, looking at the environment around the meal, etc. And meal times can be agony for some of these families. And so I always make a point of emphasising the importance of limiting meal times, that asking parents just to walk away, maybe to explore strategies that aren't working, and gently support them in maybe moving on from using those strategies if they've not been found to be effective. I was talking to a family this week and mum's cooking like 4 or 5 meals, and the child doesn't want to eat them. And you say, well, that's not working. So let's have a think about what other things you could do. So with our patients with advanced disease, let's have a little think about what's going on in terms of nutrition. So underlying it, many of these patients will become malnourished. Some may lose weight, some may have what they call sarcopenic obesity, so they might have lost muscle mass, but might have still quite a lot of body fat. But most of them will have a degree of malnutrition, particularly as the disease becomes more difficult to control. And that is a complex thing which could take a couple of hours lecture all on its own if we look at cachexia. So cachexia is a phenomenon that you will see often in advanced disease. It is not particularly reversible unless you can control and reverse disease process, and it's associated with a lot of different it's not hugely well understood, but there are definitely some physiological changes in perception of appetite, changes in the way the body processes nutrients and uses its muscle mass, which bring around cachexia. And you see cachexia in AIDS and HIV AIDS, you see it in end-stage cardiac failure, as well as perhaps most notably in cancer. We also see some patients experience increased losses, so with horrible diarrhea, with emesis, they might not be absorbing as well, and if you've got lots of secretions, that also may contribute to some dehydration or some loss of some electrolytes. Decreased intake is we're going to look at in a minute, but that is probably the factor that we can maybe try and assist with, and also generally try and look at a medical support as well as self-help measures to support with trying to counteract the factors that cause a decreased appetite and intake. And then increased requirements is a bit controversial. There's very little work looking at children's energy and nutritional requirements in cancer, and the studies that are there are quite flawed because they're perhaps looking at old treatments that we don't use anymore, or they might be the methodology they use to measure requirements. Unfortunately, those things on your Fitbit or your phone that tell you how many calories you've used are actually very, very inaccurate, and so for most of the children, they don't have particularly increased requirements from my experience, partly because they are generally perhaps less active. So I think any disease-related increase in requirements is probably counterbalanced by a decrease in activity in these patients. So they probably haven't got hugely increased requirements. The only group that I see consistently requiring more calories than I expect them to require, or other nutrients, would be perhaps the young teenagers, particularly the boys who are in that phase of growth spurt. So decreased intake, obviously, all of us who are working in this field are very familiar with the factors that can lead to a decreased intake in this patient group. So Mucositis like this, one would hope you wouldn't be seeing with a patient in advanced disease, but it does happen, particularly secondary to infection, or if they are still recovering from the impact of head and neck radiotherapy or So what do we mean by decreased intake? Many factors, including nausea, vomiting, taste changes, but things like constipation will have a part to play in reducing intake. We have children that have acquired some sort of fairly unhelpful disordered eating patterns. We've all come across that family, haven't we, who are cooking meals in the middle of the night, who are perhaps going out to the supermarket or the 24-hour petrol station to get a beloved bar of chocolate or a request, and that can become a very toxic relationship with food, and also places an enormous pressure on the families. So one thing we can do and say to our family is, if they really want it, they can wait until tomorrow, but maybe just provide something small and look for an alternative. And I normally say to people, limit the food choices to 2 to 3 items per meal. Otherwise, you find the mums and dads are cooking and cooking and cooking, and the patient is still just, oh, I don't really want that, and I don't really want that. And let's be honest, most very young children don't really know what they want to eat. They know they want food, and the parent is often very good at being able to anticipate it. But there should be no there's unlikely to create a massive benefit in terms of nutrition or feeling satisfied if you need to go out and cook a meal or whatever. That generally doesn't work as a strategy, but does leave some very tired, very fed up parents, and also costs a lot of money. Tumour size and burden will obviously make a massive difference to these patients' ability to eat and drink. Obviously, with our children with large abdomens, perhaps secondary from neuroblastoma or difficult to treat Wilms tumours, they will often find they are suffering from a lot of very early satiety, not feeling very hungry. So I'm just going to look at a couple of the top ones to give you some tips that I've found helpful. And I suppose the other thing we need to think about with this patient group is steroids are often used for palliation of symptoms, and have that helpful or unhelpful side effect of steroid-induced hunger. We see a lot of the patients are very hungry, and that group tend to be our brain, not exclusively, but tend to be our brain tumour population, and those are the patients who we're perhaps more likely to see dysphagia as their disease advances. So you've got a double-edged sword of a child who's very hungry, but actually isn't able to eat enough to meet the hunger. So my experiences of using managing poor appetite and anorexia in this patient group would be that you're really wanting to make sure that there are no symptoms that we can be exploring and treating and supporting with that are acting as barriers. Obviously, things like oral thrush can cause horrible taste changes as well as soreness, and it's always worth having an assessment, an oral assessment, to see if there's anything there that's a quick fix, that's a relatively straightforward thing. Don't underestimate the impact of nausea on appetite. And I think with our younger children, it's very difficult for them to describe nausea and to articulate when they feel sick. They know when they're being sick. They might call it tummy pain, but that's also worth exploring. The old-fashioned little and often gentle encouragement, perhaps relaxing restrictive diets, sort of history of diabetes or some renal restrictions, seeing if there's any scope to relax those restrictions, and reassuring the parents and having a discussion and a reassuring discussion when the time is right, saying, well, this isn't unusual. They're probably needing a little bit less at the moment as they're not feeling so well. They're not quite as active, providing that reassurance to the parents. And appetite stimulants, we get a lot of questions from patients, particularly when we have a lot more patients going to the States for protons. They would often come back on an appetite stimulant. The research for appetite stimulants is extremely poor and is very limited. And most of the agents, such as megestrol acetate or progesterone acetate or nabilone, there is very little evidence, but it makes you feel better that you've given a medication. And I would argue that these children don't really need to be on any medication that isn't strictly necessary or isn't helping them. The only appetite stimulant that I have consistently seen that does help appetite is dexamethasone. Even other steroids are not quite so impactful on appetite, but it obviously comes at quite a price and isn't something that we would go to first line as purely to support eating. Fatigue is another issue, and our older patients, we're perhaps talking to them about trying to avoid filling up on caffeine and lots of sugary drinks to avoid those rebounds. And again, reassuring parents and patients to try and choose that best time of day. I've just been talking to a patient on the ward, and mornings are rubbish, but as the day goes on, he'll go from drinking virtually nothing to almost like 500 mils of milk before going to bed. So you work with when it's their best time and trying to reduce that pressure around meal times. Nausea and vomiting, generally dietary measures are never going to be your first line, but people do like the idea of using self-help measurements. And so for our palliative care patients, often it's disease that's causing the symptom, particularly in our brain tumour patients. Many of our patients will be receiving palliative chemotherapy, and we need to be being vigilant that we're making sure that they're on regular anti-sickness. And there are lots of different antiemetics, but also you can give them in different combinations and check on the timing. Constipation, bowel obstruction are another big thing that we see in this patient group, and so you just want to make sure that you're optimizing that management. On the whole, most patients who are feeling very sicky, and we definitely see more of that in our older patient cohort, will respond to perhaps trying some self-help measures, such as trying fizzy drinks, trying ginger, and there is a little bit of evidence of the value of ginger in antiemetic management. Cold foods, because they don't have a smell to trigger that horrible feeling of nausea that you can get. Taste changes generally don't always go away, even if more intensive treatment is completed. And so looking at using different tastes and textures and experimenting with different types of mouth care may help the patients move on with the taste changes, and reassurance that it's a really common problem. A dry mouth can be another factor we see in advanced disease, mainly driven by high use of analgesia and medications such as hyoscine. And obviously some of our patients will have already received radiotherapy that has affected the saliva glands, including total body irradiation. Having cool drinks, having sips between foods, moister foods. It is amazing the number of patients that you go, have you thought about not having the sandwich and having something a bit softer and a penny drops? And they go, oh yeah. But because they always have sandwich for lunch, then it's quite hard to get people to move to try something different. The artificial saliva sprays are universally not really liked, but people do like to try them, and the one we're using more of at the moment is the biotin range. It doesn't give you a sustained moist mouth, but it can be helpful. Digestive problems, we do see diarrhea in this patient group, and obviously you want to look at the etiology of that before you start limiting dietary intake or making any diet changes that might limit the child's choice of foods, and obviously having a chat with the team to see the wider MDT to see if there's anything else going on that we need to treat to alleviate this symptom. But constipation is probably our bigger enemy, and really looking at the literature, there's very little about what dietary changes can be helpful in generally for constipation in oncology patients, but it's particularly problematic in children because of the extensive use of vincristine. In our palliative care patients, obviously analgesia is very constipating in its own right. Ondansetron is another culprit for constipation, and your best case is to use laxatives. No amount of dietary fibre is generally going to be able to manage the constipation effectively, as the mechanism by which constipation arises isn't because of a deficiency of fibre in the diet. It is much more complex than that and is around nerve conduction and motility in the gut. So perhaps the thing that people feel most anxious about is, well, what do we do? What nutrition support can we do? What can we, where should we pitch it? Should we be being aggressive? Should we not be aggressive with our nutrition support? I'm just going to explore some of my reflections on that with you, if that's okay. So first of all, we need to think, what's our aim? Is our aim to treat the malnutrition or meet nutritional requirements? I would argue very rarely is it indicated that you are trying to get high energy input, you're trying to reverse malnutrition. Very, very occasionally we have done that, but it has been because of a very specific set of circumstances where a family have perhaps been not wanting to use aggressive nutrition support, and that child's prognosis is much better than they anticipate, and that they are actually would benefit from additional nutrition. But on the whole, the patients we see in this situation with advanced disease, when you're aiming to alleviate symptom, and that symptom might be hunger, it might be appetite, it might be that they need some additional hydration. Extending life, I think, is something that's really difficult. I had a recent case where a patient had had a very poor prognosis, but the family were not happy to contemplate reducing enteral feeds, and that patient continued on enteral feeds until he passed away. And at times, the community nursing teams were having to step in to try and reduce the amount of feeds being given, as the patient was suffering from aspiration occasionally, but also discomfort. Even though, unfortunately, the patient was non-verbal, reading the room, you could see that the patient was feeling quite uncomfortable with all the feeds. So sometimes providing that nutrition, and this is where we can be very powerful and helpful with our families, discussing nutrition, having a chat about what it can achieve, and maybe looking at lovely interventions that people can do, whether that might be making a much loved traditional food, or having fun movie night, and reassuring the family that having white chocolate and corn and popcorn this evening sounds like an amazing idea, and that sounds like a great diet. Those are another thing that we can do, and that might be the aim of our intervention will be purely that you are providing reassurance and you're holding them safely by saying, yeah, that's okay. And as dietitians, because generally we've met these patients earlier in their treatment protocol, in their journey through treatment, we've often been talking about, and as have the medical and nursing teams, you need to keep their weight up, they need to eat more, they need to drink more, we're all focused on that. And so having to make that swap from being a parent who's there saying, look, they've got to get the weight up because then they'll get more chemo, or they need to be well nourished, otherwise they won't be able to go onto that trial, to then going, oh no, that's okay, it doesn't matter, is quite a big switch. And so we need to be sensitive in how we handle that. We also are there to advocate for our patients as well, aren't we? And if we've got families who are very fixed on the nutrition in some form or other and are putting a lot of patient pressure on the patient, we need to be stepping in, because we are there to advocate for those who cannot advocate for themselves, and also act as referees sometimes, to be honest. But it's an area that is normally explored by the wider team, and I think if we all give the same message, that's very comforting for both the parents and the children. And we want sometimes actually being more interventionist with your nutrition intervention, so perhaps even placing a feeding tube preemptive at this point, because it might take some of that burden off the patient and the families in terms of hydration and medication administration. So it's definitely not a do not tube feed situation, which is very interesting because they struggle with that hugely in our adult service. And I recently had a patient, an older patient who's 20, who was under an adult team and had started to develop dysphagia, and they couldn't see where I was coming from with my, well, what about using a gastrostomy? Because as you know, as I'm sure you're all familiar, a lot of our young adults tend to exceed life expectation because they have, strong hearts, strong lungs, strong livers, and are, in other respects, apart from their disease, very fit and healthy. And so we discussed having a feeding tube, we discussed having a gastrostomy with this patient, which was something that was quite anathema to the adult practice. It's also very rarely that you will see an adult hospice team placing an NG tube, whereas that is a much more common experience in our palliative care world. We also need to act ethically, and I was sitting in on a presentation to Ghana yesterday where we were talking on the same topic, and interestingly they were looking at the 4 principles of acting ethically and brought up the issue of justice, which perhaps working in Europe we're maybe not having to be quite so conscious of this idea of there are already so many resources, and where do you need to target your expensive nutritional products, for instance. So the ethical considerations are there for all aspects of nutrition support in all patients, but particularly we need to be mindful of these when we're dealing with this patient group. There you go. So nutrition needs to be a team approach. We all need to work together. Normally I'll get a phone call or a tap on the door saying, oh, we're going to put a tube down. Little Betty, she's at home. What would you recommend? And so if we know the families beforehand, it's actually a lot easier because you can know if that family would like to, if they've had feeding tubes before or not. And also if you don't want to go down that route and would like a different type of route, we might be able to provide them with some nutritional supplements, as that can often make the family feel like they're doing something. So we have the food first approach, which is obviously the nicest approach for the families. You pitch your intervention depending on prognosis, and you can often give some very simple advice around adding, nut butters or additional butter, ghee, adding extra cheese, nuts, pulses, something that you think will perhaps not be overburdensome for the patient, but will be potentially beneficial, but also beneficial for those persons providing the food, as it helps them feel engaged and supportive around food and nutrition. Obviously, if you're not based in the UK, you're perhaps not familiar with this book, but it is freely available on the CCLG website, and you can use the website to translate, Google Translate, it'll translate it into different languages. Nutritional products are not always valuable, are not always used in different parts of the world and in different countries. In the UK, they're relatively easy for us to access. I would say they're relatively unpopular with the patients, but the parents are often wanting to ask for something that is a nutritional supplement drink, or carers will, or healthcare staff might ask for that, because we're all human after all, and we all want to do something, we all want to help. And we do give quite a few of the supplements to our palliative care team to take out to patients, and have a low expectations of patients taking them, but it at least shows the families that we are engaged, that we are aware of their concerns. And that is one piece of, that's one nugget that comes out of the adult world, is this anxiety and distress that carers, parent carers, family carers express when they feel that healthcare assistants aren't taking their concerns seriously about nutrition, because they are not experts in this field and do not have a lot of experience in this field to know that a reduction in appetite is a natural part of advancing disease process. We do use enteral tube feeding in our palliative care population. It is very individual dependent. Some patients will say absolutely do not want to have a feeding tube, and the team will work very, very hard to find a way around that using medication, working very closely with the children's community nurses to provide medication IV if required. For some, particularly the brain tumour population, it is often indicated fairly early on if the swallow is failing. And what I tend to do is come up with a very, if they've not used a feeding tube before, come up with a very light touch feeding regime, which is one that might have some bolus feed so that the family don't have to learn how to use a feeding pump. We would also encourage families to place other things down the tube, like juices or thin soups, as that can perhaps be more comforting and quite feel more natural, as it were, than using solely relying on sup feeds, commercial feeds and other products such as those. Generally, the indication for feeding tubes in my clinical practice and with our team, it isn't normally the only reason to place the tube, would not be nutrition. It's normally a factor, several factors, sort of hydration and medication administration perhaps being the top indicator. And for those children who are already on feeds, it's perhaps working with the palliative care team and supporting those families to reduce the feeds, having those discussions about reduced requirements, the burden of tube feeding. So you can use tube feeding fairly in quite a few of the patients, but what you need to look at is your expectations about what you can achieve with it. Obviously, you're not going, if you've got an older patient, it is their choice. They don't have to have a feeding tube. It's perfectly fine if they don't want to have a feeding tube. And you wouldn't think to try and feed in bowel obstruction or if there's severe profuse diarrhea. So for me, the things I think about when I'm seeing these patients is what to give, how to give it, gravity, pushing through boluses, particularly useful for older children because it's very, very difficult to hold a 100 mils of syringe and infuse that really slowly. And a pump a minute, we have started some patients with a feeding pump if required. Obviously that is a bit easier if you've already used one. And how much to give? Well, you're trying to give enough to control your symptoms. So if your symptom is hunger, we try to infuse a small amount of feed, or might look at a meal pattern depending on how the child has been responding to the boluses. But what's really important is that the benefit and the burden are matched. So you're not trying to overfill this child, that then will cause a risk of aspiration, nausea, vomiting, diarrhea, bloating. So you want to tread carefully. And I know it's really difficult as dietitians sometimes to feel that you're not meeting their full requirements, but that is okay. This is the article I mentioned earlier. This is actually the algorithm that we came up with. I mean, it's not evidence-based, it's sort of experience-based, and it is a very conservative feeding plan, which we decided as a team we felt was sufficient to meet both the child's needs, but also make sure that you don't overburden with feeds, but also that you are doing something that is acceptable to both the healthcare professionals and the patient and the carers. PN is not widely used in home in advanced cancer, although that has changed quite a lot in the adult world, and I suspect that pediatrics will start to catch up with that. It's partly because in adults you have a lot more patients whose disease causes bowel obstruction than we see in children and young people. And obviously it's extremely resource intensive, expensive intervention, and isn't something that one would like to see that we should be doing routinely, but there are occasionally exceptions to that rule, and if we get time I can show you a case study where we had a lot of discussion around this. I am not an expert at end-of-life care. There is not really a place for a dietitian in end-of-life care, but we generally would advocate the withdrawal of the nutrition support as the patient becomes more unwell, and a very light touch regarding nutrition, which will be led by the palliative care team and the community nurses or hospice nurses. So what time are we at? Oh, I've nearly done all my time. Just very briefly.
No, yeah, sorry, Louise, just take your time.
And yeah, am I okay to do this bit, or do you want me to? Yeah. So
carry on.
Complementary and alternative diets, we see a very big uptick in this as patients develop more advanced disease. And obviously parents are on the internet, they're looking at articles that tell you that sugar feeds cancer, that bone broths help give you stronger resilience and help your immune system. And so we find that we are often discussing these types of diets with our patients with advanced disease. Just for those who aren't aware, the term complementary normally indicates a sort of a dietary intervention you would do alongside treatment, conventional treatment, with alternative being something that you would give in place of conventional treatment. Now, obviously, for some patients, they have come to the end of the road when it comes to treatment options. And for those patients, they might be looking to use the alternative diet therapies. Interestingly, most phase 1 studies will exclude patients who are following alternative or complementary diets or using a lot of herbal products. And I recently had a patient where the consultant was unaware that she had basically cut out carbohydrates for the last 18 months from her diet. Partly he was unaware because she hadn't told him, but secondly, she was never ketotic, so she wasn't following it particularly effectively. So the current trends in the UK, and they do vary around the world. So going back to my discussion about yesterday with Ghana, their big current hot favourite topic is alkaline diets. Whereas I think in the UK, we're still pretty much the keto and then the broths. And the high dose vitamins and minerals and herbal products continue to be a common theme. If you are seeing someone who wants to use a lot of herbal products, you perhaps want to get the data, the information about those products, where they're made, what's in them, and do they have any potential interactions. If they don't, then we would perhaps, we can support families to use those products and potentially even be, putting them into the juice if they might put down an NG tube. Cannabis is illegal in the UK, but we do know that a large number of our families do use it. It doesn't seem to have a huge impact on appetite, to be honest, but whether that's because the patient group that are using it are quite poorly already, and therefore it's unlikely to make much impact. These diets can be inadequate, can be harmful because they're very time consuming, they're often very expensive, people feel guilty if they're not following them, they can cause direct harm. So for instance, there's a trend in the US to use apricot kernels, which contain something that was called B17. It's a self-appointed vitamin, B17, doesn't exist, and it's laetrile, which is a cyanide precursor that you find in apricot kernels. And obviously the diets can be very unbalanced. We also find that if you're going to be on a very restrictive diet, then that really does impact on your socialization as well, so your ability to go out and have a meal, etc. So I have had a number of patients who've been wanting to have low sugar diets, and the way it's always worth checking what the family mean by that, or the patient means by that. In fact, I've got a patient at the moment, and what that meant was he's not having any chocolate. And you think, well, that's okay. That's not the most restrictive thing. He's not on a keto diet. He's going to cut out chocolate, and I think he's going to have diet drinks. And you think, okay. And what he said to me, it was really sad actually. He's got a DIPG, so he has an incurable brain tumor, and a 17-year-old patient who wanted to just look if there was anything to do. And I explained that there was very little evidence for ketogenic diets, for low sugar diets in cancer. And that the research was confined mainly to animals and test tubes. And he said, but I've got nothing to lose. And you can't argue with that. And so we are quietly working together and trying to make sure that he gets that balance of being able to go out and have food with his girlfriend and his family, but at the same time feeling that he's doing something. And that's what's going on. People like to feel empowered, they want hope. It feels something that you're doing something rather than doing nothing. And again, going back to that cultural significance of food as a medicine. And for some of our older patients, it's a way of controlling what feels like a situation where all control has been taken away. So let's work in partnership. To summarize, working in partnership, having open conversations and realistic expectations, having the patient's interest at the center of all of these discussions, avoiding very intensive nutrition support if at all possible, and also reducing your expectations. If you're devising a nutrition plan, be mindful about what are you actually hoping to achieve with this feeding plan. And optimizing, the most important thing is using your palliative care team to optimize symptom management so that patients can, if they want to, enjoy food when they feel able to. Thank you.
Thank you, Louise. Very interesting topic, isn't it? Because end of life care, palliative care is quite broad in the sense because it's not, it may be imminent, it may not be imminent. And how we see a very basic function of living, nutrition, eating, how it's managed. So we open up the questions. Anybody has questions, either unmute yourself and ask the question of Louis, or drop the question in the chat. So, Louis, I just wanted to just chat about things. So, we often think that the basic question of feeding, eating, drinking, is very it's a tender, loving care, isn't it, towards the end of life? And have you ever encountered a family, whether in hospital or advice from palliative care team, that the family feels that it's not right to feed the child at this stage in their life? So it's a dying child who is imminently dying, but wanting to have something. So have you ever encountered it?
I think it's very complex, isn't it? Because I think every family experiences it in their own way. And the case with the patient was fed when perhaps it wasn't always in their best interest, as they were being burdened by quite a lot of feed. There were many other factors. That wasn't the only factor, where the parents were really, really struggling to take on board what was happening and to process that. And so nutrition was like one factor in that sort of thing, where you've got somebody feeding, you think, well, I'm really not sure you should be feeding that much. And we tried to make the feeding plan as unintensive as possible, but it just shows something with those really complex situations where you've got all of that confliction. You need to be working very closely with your team, because that team, the palliative care team, are going to be the people that are consistently having those difficult conversations. I think as dietitians, or those who are perhaps predominantly giving a lot of nutrition support advice, you're probably not the best place to have those conversations, because they aren't just normally about food. There's a lot more going on, isn't there? And most families are just gently get to the point where they start withdrawing the feeds, and which is why I'm quite a big advocate of recommending like juices and teas and things down tubes, because it feels like it might be that it is a more natural and a less medical intervention, even if it has to go down a tube. I don't know, Mary, what do you think?
I think so too, but you see, at the end of the day, it's more the balance and the trust and advice, healthcare professional with family, to work towards the comfort of the child, isn't it, the patient? Because sometimes if they are not comfortable, it's difficult. So the main thing is to make sure we have the symptoms under control, manage the symptoms regardless.
Yes. Yeah.
And then the nutrition and the feeding comes in. I'm just looking at the chat now. There isn't any more questions on the chat. There's one. Hi, Mecca. Yeah, feel free to ask the question if you want to
Yeah,
unmute
hi.
yourself. Hi.
Yeah, hi. Thank you for the presentation. Really very interesting. Just at the back of, as you've said, that it's not really, nutrition is not really a main thing, and you've said that you do recommend sometimes putting soup or tea down the tube. Is that even down like the NG tube? And do you think that that could, like, have any damage to the tube, or would then reckon changing the tube, which may not be ideal in these patients? What do you think?
Yeah, good point. I mean, we use an 8 French tube generally, and some of our patients have already got gastrostomies. So the volumes that we're talking about are generally quite small. So if it's a new patient, I would normally start with something like a 50, say give a 20 to 30 ml bolus, which is, very, very small, but has a perhaps a value beyond its nutrition for the family and for the patient, might make them feel that they're doing something. We normally send out a little patient information thing which will suggest that they're sieved and things, but the food is probably no more damaging than the medication that's going down that tube, and none of these tubes have been if you look at their compliance, most of these tubes have not been tested with medication, and they've not been, so we're almost like using them unlicensed. And again, we're not talking about massive volumes. I absolutely take your point there. You do not want to block that tube because that is to be avoided at all costs. We tend to use a particular type of tube that is a longer term tube rather than a 10-day tube, precisely for that reason. And also the cheaper nasogastric feeding tubes, the ones made with PVC rather than polyurethane or silicone, those tubes tend to harden really quickly at the back of the throat and into the stomach and cause gastric erosions. So if you're wanted to invest in something, I would highly recommend that you're investing in a higher quality feeding tube in this circumstance to prevent exactly what you said, Megha, which was to avoid replacement of a tube at this stage.
Yeah,
Thank you so much.
Yeah.
Thank you.
It's working in partnership with the family to see what is right, isn't it? And on the note of the soup going into the tube, in our previous webinar session, they did blenderize the food and sieve it. So that is another option one can do in this stage. The Sinead, is that right? Sinead Evans, do you want to ask a question?
Yeah, hi. Sorry, my mic is down. Hi, I was just wondering, do you explore a blended diet for your palliative patients who aren't, say, who say death isn't imminent, say maybe they've got 6 or 12 months, say, to live? Do you use blended diet for symptom management in that group, and do you find it beneficial?
Yeah, I think it could be really helpful when it comes to bowel management. And I know the dietitians on the call are probably aware of the product that one of the companies has some food-containing items in it, which is also being used now in adults. Yeah, I think so, and I think it does serve another purpose. I think it really helps feed into that food as food for the parents as well. And many parents will request something that if they would like something that is natural, and particularly if disease is becoming perhaps more difficult to treat. Obviously, it's quite hard with children to give a guesstimate of end of life and how long they've got, but we absolutely are now, we are definitely much more open than we were perhaps 5 years ago, even about encouraging families to do that. We've always encouraged the palliative care people when we're starting them to think about using juices, and that comes back from that coming up as a request a lot earlier in my career. So many people go and see nutritionists or have friends or have gone on the internet and have seen the power of juice or smoothie, and obviously a lot of the children will say, well, I'm not going to drink that. So if they've got a tube, they might like to do that. But yeah, we are definitely advocating for that. Very difficult for us to do in our hospital, but we can find ways around it. We also have a huge number of people with broths that want to use broths, which I mean, I can't find any nutritional value to those broths, but it makes them feel like they're really, again, helps the families feel that they're doing something at a time when they're perhaps not able to do much.
Yeah, absolutely.
Yeah, that's important.
And how do you get around food safety? Because at the trust that I work at, we are quite anti-blended diet and not something that we support on the ward due to the infection control side of things.
Well, most of this is at home, which does make it a bit easier. On the ward, when we've done it on the ward, we have done case-by-case assessment of it, and we've actually even done a blended diet for a transplant patient. But if you're a member of the Paediatric Oncology Dietitians Group, the BDA, I have presented on that, and I think it's actually on our website if you want to see our experiences and how we managed it. And I do apologise to the rest of the UK because I know that that family have then gone and told everybody else. So that's probably getting a lot more work to other centres. Sorry.
Yeah, but might be useful to share that website link when you have a moment.
I think unfortunately it's behind a paywall, unfortunately, Mary. I'm
Okay.
afraid it's not
Yes.
publicly accessible. Sorry.
So no, that's fair enough. So if anybody finds the topic interesting and want to open the discussion further in our PsyOp Europe Nursing Working Group, do come along. We welcome advisors, expert advisors like Louis, dietitians who are maybe on the line on this call to join the group. We always welcome their expertise in trying to move forward with the nutrition in cancer patients. I put in the link there. And without any more questions, I would like to thank Louis. It was an interesting talk. As usual, your talks are always very interesting. So thank you. I put in the QR code for you to do your evaluation. It's very important we get the evaluation because all these are not funded. It's all through goodwill of people who volunteer their time to do it. So thank you very much. And then we are going to do the last of the nutrition webinar series. Can you see that? And that is the last one in our Nutrition Nuggets series. And it will be held on the 14th of October. And it's another interesting and topic. Lots of discussion to be held. So I hope to see you on October 14th via this link for this session. I'll leave that on for a while in case you want to scan the QR code for the registration. But thank you very much, Louise. Yeah, we'll try to feedback the survey evaluation once we have analyzed it and process it. Okay, so thank you very much for all your participation, everybody. Nice to see you all. Thank you very much.